We are going to start as usual with a didactic presentation, which I will be providing. And let me go ahead and get that launched. So I am going to be talking about the diagnosis of tuberculosis in HIV-infected patients. This is kind of a follow-up on our opportunistic infection series. As you may recall, 2 weeks ago, I gave a talk on prevention of tuberculosis. Now we're going to move on to the diagnosis of TB, especially in people with HIV infection. I have no relevant financial disclosures. These are our learning objectives. Hopefully by the end of this talk, you will be able to describe the clinical manifestations of tuberculosis in HIV-infected persons and how they might differ from that of individuals who do not have HIV. Review the appropriate use of diagnostic tests for tuberculosis in people living with HIV infection, and specifically discuss the use of nucleic acid amplification tests, such as that used by the expert TB RIF system in diagnosing TB infection and detecting drug-resistant TB. So without further ado, let's get into the content of the talk. So the first thing to know about TB and people living with HIV is that its clinical presentation is very much influenced by the degree of immunodeficiency. For example, in HIV-infected patients who have CD4 counts over 200, so a little bit, healthier, the TB generally resembles that which is seen among HIV uninfected persons. Majority of patients have disease limited to the lungs, and in the lungs, it's usually seen in the upper lobes, upper lobe infiltrates with or without cavitary lesions. But when you are dealing with patients with low CD4 counts, less than 200, there are some key differences. Chest X-ray findings, for example, can be very different. The infiltrates can be anywhere in the lung fields. It's actually uncommon to see cavitations in these patients because they lack the immune response necessary to sort of develop these cavitations that surround the mycobacteria. And one can actually see completely normal chest X-rays. So, for example, this is kind of a classic X-ray presentation of a patient with pulmonary TB in someone who has an intact immune system. So you see upper lobe infiltrates, and you can see a couple of cavitary lesions, a very classic TB. This chest X-ray actually comes from a patient I saw just less than a week ago in clinic, who is HIV infected with a CD4 count of about 180. And it's really not very impressive at all. At first glance, it looks like it's normal. There may be some lower lobe infiltrates, maybe a little bit of hilar fullness, suggestive of lymphadenopathy, but it certainly in no way resembles a classic picture chest X-ray for tuberculosis. Furthermore, with increasing degrees of immunodeficiency, extrapulmonary TB becomes more common, as does disseminated TB. And tuberculosis can infect just about anywhere in the body. I think lymphadenitis is a really common manifestation, but you can see pericarditis, meningitis, encephalitis, even ocular involvement. In fact, the patient I just presented, whose chest X-ray I showed, she was diagnosed with TB based on vision problems, and it turned out she had a tuberculous uveitis that led us to test her sputum. Now, the clinical manifestations of extrapulmonary TB are really not substantially different from those described in HIV uninfected persons. It's just that they're more common and you have to have a higher degree of suspicion for them, especially a high degree of suspicion for processes that involve the central nervous system, because if left undiagnosed and untreated, these can be rapidly fatal. So that's sort of the clinical presentation. Now, diagnostic testing really is directed at the anatomic site where signs and symptoms are presenting that makes you suspect TB. And again, most commonly it's the lungs, but as I mentioned, with extrapulmonary TB being common, you may be looking at other specimens, urine, CSF, lymph node aspirates, to look for the tuberculosis. Now, having said that, in any patient with suspected TB, even if you think it's extrapulmonary, you really should get a chest x-ray, even if that patient has no pulmonary symptoms or signs, because pulmonary involvement is common actually at all CD4 counts of disease. Again, the patient I showed the chest x-ray earlier, she does have pulmonary TB. The bacteria grew out in the sputum, even though she did not have a cough, and her presenting symptoms were ocular. It's worth noting, however, that chest x-ray is not a perfect screen for pulmonary TB. And as I mentioned, in advanced HIV disease, the chest x-ray can be completely normal. So it's arguably not enough to do just a chest x-ray when you suspect TB. Even in patients who don't have clear pulmonary symptoms, it's probably a good idea to get a sputum culture as well, because it could be hidden in the lungs, especially in patients with low CD4 counts. Now, smear-negative TB is common among people with HIV infection, especially those with advanced immunodeficiency, and that's probably owing to the fact that you don't see the cavitations in the lungs. Those cavitations are where the mycobacteria can really concentrate and produces the numbers of acid-fast bacilli that can be seen in a smear. But while the smear may not be as sensitive for detecting TB in people with HIV, the cultures are just as sensitive. And they are really, the sensitivity of culture is not affected by HIV or the degree of immunodeficiency. So sensitivity is very high if a broth culturing technique is used, which really is the standard of care for tuberculosis culture. It's recommended to do at least, to do 3 sputum specimens. With each successive specimen you smear and culture, you get an incremental yield. So in your patient with HIV, please do obtain 3 sputum specimens, send all for smear and culture. Now, one extrapulmonary manifestation that I think deserves special mention is TB lymphadenitis, because this is a fairly common presentation. Lymph node involvement is common in HIV-related TB. Fortunately, it's typically not that hard to diagnose. Excisional biopsy of a node or even simply fine needle aspirate from a node should give you the diagnosis if you do histopathology, smear, and culture from these samples. You may see some differences in the histopathologic findings according to the degree of immunodeficiency as well. Now, a more sensitive technique that's certainly gaining favor and is becoming more widespread is the use of what's called nucleic acid amplification testing for tuberculosis. This is a molecular kind of test that looks for essentially mycobacterial DNA in the sample. And they have several advantages over smear and culture. They are more rapid, and they are more sensitive than smear. Not quite as sensitive as culture, but they can be quite sensitive when you perform multiple tests on the same specimen. And furthermore, they are able to quickly distinguish between TB versus non-TB mycobacterial infections. And of course, there are a number of non-TB mycobacterial infections that our patients with HIV can contract. It's important to be able to determine which one is at play here, and these tests can typically tell you immediately. So, nucleic acid amplification testing is recommended on at least one specimen from all patients with suspected pulmonary TB. They can also be used on extrapulmonary specimen, but their sensitivity is often lower. Now, the system that employs this technology that is most commonly used and has been widely rolled out is the GeneXpert system. The Expert MTB RIF assay, as it's known, is an automated nucleic acid amplification test that can detect both MTB and it can also, importantly, detect mutations in the samples that are associated with rifampin resistance. Turnaround can be very rapid, as little as 2 hours. It has high sensitivity and specificity, 88 and 98% respectively, although it is a little bit lower among patients with HIV. Extrapulmonary specimens performance varies according to what kind of sample you're dealing with. Lymph nodes, very highly sensitive. CSF, also pretty good sensitivity, 85%. Gets a bit lower with serous fluids, and pleural fluid, only 34%. So again, important to back it up with cultures as well. Now, the drug susceptibility testing is quite important. And it really should be performed on all initial isolates for patients suspected of having TB. Because if there's INH or rifampin resistance or both, there is definitely an increased risk of treatment failure, recurrent TB, and amplification of resistance to additional TB medications. So ideally, all patients with TB disease, drug susceptibility testing is performed to all 4 of the first-line TB drugs, the rifampicin, isoniazid, ethambutol, and pyrazinamide, regardless of the source of the specimen. Furthermore, drug susceptibility testing should ideally be repeated if sputum cultures remain positive for MTB at or after 4 months of treatment, or if they become positive 1 month or longer after initial culture conversion to negative. Now, how do we do drug susceptibility testing? Well, there is the conventional phenotypic drug susceptibility testing where you essentially have a culture of MTB in a media that contains the anti-TB drug. However, this is a slow process due primarily to the fact that MTB grows very slowly in culture. And so far better to use the nucleic acid amplification testing, which looks for the signature genetic mutations that confer resistance to rifampin, for example. And there are also line probe assays that have similar technology that can look for resistance to isoniazid. And while there have been some reports of false positives, these are less common with the current version of the assay. So just to wrap up with our key points, tuberculosis can present differently in persons living with HIV as compared with HIV uninfected individuals, particularly among those with advanced immunodeficiency. And the key differences being that chest X-ray manifestations can be very different and more subtle in people with HIV and advanced immunodeficiency, and extrapulmonary TB manifestations are more common in those individuals as well. Sputum smears are less sensitive for detecting TB in HIV-infected patients with pulmonary TB, but the sensitivity of culture remains high and is not at all diminished by HIV infection or advanced immunodeficiency. Nucleic acid amplification testing, such as that used in the Expert assay, have several advantages over conventional smear and culture detection techniques, including rapid detection of rifampin resistance. So I'll wrap up there and take any of your questions.